Welcome. In this session, we are going to discuss choroidal and ciliary body melanomas. Ciliary body and choroidal melanomas are together grouped as posterior uveal melanomas, and they are the most common primary intraocular malignancy in adults, and they are a potentially fatal disease. Incidence in Western countries has been reported to be 6 cases per million, and the incidence is higher in higher latitudes in those countries. However, in Asia, incidence is reported to be tenfold lower at 0.4 cases per million. Mean age of onset in Western countries is 60 to 65 years of age, but mean age of onset in Asian countries is reported to be much lower at 45 to 50 years of age. Risk factors for the development of uveal melanoma include fair skin, which does not tan, ocular melanocytic lesions such as choroidal nevi, which has a lifetime risk of 1 in 500 of choroidal melanoma occurring, ocular and oculodermal melanocytosis, which has a lifetime risk of 1 in 400 of uveal melanoma occurring, genetic predispositions such as dysplastic nevus syndrome and mutations in the BAP1 gene. This photograph shows a patient with oculodermal melanocytosis. We'll first describe the clinical features of choroidal melanoma and then describe the clinical features of ciliary body melanoma. Many choroidal melanomas are asymptomatic and are detected only on routine dilated fundus examination. Photopsias or flashes can be the only symptom of a choroidal melanoma. Patient may complain of visual field defect when the choroidal melanoma is large or when the associated subretinal fluid is extensive. Patient may also complain of loss of central vision if the tumor is located in the macula or is large enough to obstruct the macula. Floaters can occur from vitreous hemorrhage when the tumor invades through the retina, and there can be signs of ocular inflammation in up to 5% of uveal melanomas. Typically, the more peripheral the tumor, the larger it has to become to cause symptoms. On examination, a choroidal melanoma appears as an elevated lesion, usually more than 2 mm in thickness, which is variably pigmented, and the color can vary from dark brown to amelanotic. Hypomelanotic melanomas show prominent intralesional vascularity, and growth of the lesion can usually be documented within 1 to 3 months. A choroidal melanoma usually has any one of 4 growth patterns. The dome-shaped pattern is the most common growth pattern and represents intrachoroidal growth as shown here in this diagram. In these 4 diagrams, the blue line represents the retina, the orange line the Bruch's membrane, the yellow portion represents the choroid from where the tumor arises, and the green portion represents the sclera. So the dome-shaped growth pattern represents intrachoroidal growth, and in the dome-shaped growth pattern, the thickness of the tumor is usually half the basal diameter. In this photograph, we see a dome-shaped choroidal melanoma. The diffuse growth pattern, as shown here, also represents intrachoroidal growth without invading the Bruch's membrane, but the thickness of the tumor here is less than 20% of its basal diameter. In the irregular growth pattern, which is also an intrachoroidal growth pattern without invading the Bruch's membrane, the tumor has geographic margins with nodular surface. The mushroom-shaped or the collar button-shaped growth pattern is the most characteristic growth pattern of choroidal melanomas, and this occurs when a dome-shaped tumor breaks through the Bruch's membrane to have a subretinal nodular component. And the break in the Bruch's membrane can be eccentric over the dome-shaped portion of the tumor. Because of this break in the Bruch's membrane, choroidal melanomas with a mushroom-shaped growth pattern can be associated with subretinal seeding and or hemorrhage. The subretinal component of the tumor may be smaller in size, similar in size, or larger as compared to the dome-shaped component. In this photograph, we see a mushroom-shaped tumor with evidence of the dome-shaped component lying underneath. As we have discussed in the previous session, surface features suggesting malignant nature of a choroidal melanocytic lesion include surface liposuction and serous retinal detachment. Surface liposuction is usually detected in smaller actively growing tumors. and it appears orange over pigmented tumors and dark colored over amelanotic tumors. Serous retinal detachment occurs commonly with choroidal melanomas and can extend beyond the tumor, particularly with a larger choroidal melanoma. A massive serous retinal detachment can push the lens iris diaphragm forward and lead to secondary glaucoma. What is important to understand is that during follow-up, a long-standing stable choroidal nevus may be detected to have developed these surface features, suggesting malignant transformation of that lesion. Choroidal melanomas may ultimately break through the retina, resulting in vitreous seeding and/or vitreous hemorrhage. Vitreous seeding in choroidal melanoma appears as a pigmented streak in the vitreous cavity arising from the anterior surface of the choroidal melanoma. A peripapillary choroidal melanoma tends to invade the optic disc, and larger choroidal melanomas may have iris neovascularization in the anterior segment. Some melanomas, after a period of active growth, can enter a quiescent phase for months to years. When they demonstrate benign features such as drusen's and RPE changes and lack malignant features such as liposuction and subretinal fluid. During this period, these lesions have a low risk of metastasis, but they should be followed up closely for detecting active growth in the future. Ciliary body melanomas are usually detected late because of their location, and symptoms include reduction in vision, which can be due to cataract formation or due to astigmatism. Astigmatism can occur due to involvement of the zonules or pushing on the lens by the tumor. Photopsias can occur, and there can be visual field defect due to an associated retinal detachment. Pain can occur from secondary glaucoma. On examination, we find a dark retrolenticular mass after pupillary dilatation, and this is more easily detected against a red reflex from the fundus. The tumor has to be at least 3 mm thick to be detected. Transillumination of the eye shows a shadow corresponding to the basal extent of the tumor. We'll discuss transillumination a little later in this session. Sectoral cataract is common near the tumor, and the crystalline lens can also be pushed and displaced by the tumor. Visualization of the overlying ora serrata without scleral depression is also a sign of a ciliary body mass. The ciliary body tumor can penetrate through the iris root into the anterior chamber and become visible as a mass in the angle on gonioscopy or in the anterior chamber. Secondary melanocytic glaucoma can occur when the tumor undergoes necrosis, dispersing its melanin. Histiocytes ingest this melanin and subsequently block the trabecular meshwork. On the external surface of the eye, we can find sentinel vessels and pigmented epibulbar nodules. Sentinel vessels are dilated episcleral vessels over the region of the ciliary body tumor, and epibulbar nodules occur due to the tumor extending extrasclerally through the scleral emissary channels. Clinical evaluation of posterior uveal melanomas are based on history of cancers in the self or family, ophthalmic examination, and multimodal imaging. Indirect ophthalmoscopy is very useful to assess the size and the extent of the tumor. Size of the tumor is assessed by comparing it with the optic disc, and extent of the tumor is judged by its relation with the normal retinal structures such as blood vessels. Slit lamp examination allows for a detailed examination for surface features such as liposuction and subretinal fluid, and to detect retinal and vitreous invasion. Gonioscopy helps us to detect angle or peripheral anterior chamber involvement. Wide-angle fundus photography is important for documentation and detecting progression or regression of the tumor over time. Standardized ultrasonography is still the most important diagnostic test to evaluate melanoma, and for that matter any intraocular tumor. By the term standardized, we mean performing a specific sequence of tests while doing the ultrasound so far as the cuts and their orientation are concerned. In the A scan, as we see in this picture, the anterior border of the tumor has a very high reflectivity, but the interior of the tumor has low reflectivity, and this is called low internal reflectivity, which is very characteristic of a choroidal melanoma. Spontaneous vascular pulsations can be detected within the tumor as fluctuations in the amplitudes of the spikes. So in this A scan, this portion of the tracing represents the melanoma and this spike represents the spike from the internal scleral surface. On B scan ultrasound, early choroidal melanomas appear dome-shaped, representing the dome-shaped growth pattern which we have discussed, and this is the most common appearance of choroidal melanomas on B scan ultrasound. Later tumors take on a collar button shape, representing the mushroom-shaped growth pattern, which, as we have discussed, is the most typical or characteristic of choroidal melanoma. B-scan ultrasound helps us to assess the size of the tumor with respect to its thickness and basal dimensions, as well as identify the location of the tumor. On the B-scan, the anterior border of the tumor shows high reflectivity, but in the interior of the tumor, though the echogenicity is regular and homogeneous, there is a decrease in the intensity of the echoes from the anterior to the posterior aspect of the tumor, and this is called acoustic hollowness or sound attenuation of the tumor. B-scan of choroidal melanomas can also show choroidal excavation as seen here in this photograph, and it occurs due to difference in reflectivity of the highly reflective normal uveal tissue and low reflectivity of the tumor. This can be found with other low reflective tumors also. B-scan ultrasound can also detect serous retinal detachment associated with the tumor, and there can be shadowing posterior to the lesion in this region, which is not very prominent in this photograph. Scan is very useful to detect posterior extrascleral extension, and intraoperatively it helps in verifying the position of a brachytherapy plaque with respect to the tumor. And serial ultrasound scans can document growth or regression of the tumor. Limitations of ultrasound include it does not image the anterior segment, and it may not differentiate between a necrotic melanoma and subretinal hemorrhage, and it may not differentiate between a melanoma and an atypical metastasis. Ultrasound biomicroscopy or UBM is particularly useful for tumors which primarily involve or invade the anterior segment. Transillumination technique is useful to assess ciliary body or anterior choroidal melanomas, particularly when UBM is not available. In this technique, high-intensity focused light, usually from a fiber optic probe, is projected inside the eye, either through the pupil or through the sclera diagonally opposite to the tumor. And in this situation, the eye, when viewed from outside, glows orange-red in color. However, if there is a pigmented mass present in the eye, that area obstructs the orange-red glow and appears dark in color. This dark area thus corresponds to the basal dimensions of the tumor. Transillumination can also be useful intraoperatively during insertion of a brachytherapy plaque. Fundus autofluorescence detects autofluorescence from liposuction in the retinal pigment epithelium. When the content of liposuction increases in the retinal pigment epithelium overlying a choroidal melanoma, there will be increased autofluorescence. The same will happen in areas of recent serous retinal detachment overlying and around the tumor. But from areas of old serous retinal detachment and RP atrophy where the liposuction content decreases, there will be decreased autofluorescence. And when the tumor breaks through the retina and becomes highly elevated, it will block the view of the underlying retinal pigment epithelium and thus block the autofluorescence from the underlying retinal pigment epithelium. Optical coherence tomography, particularly enhanced depth or swept source OCT, can detect RPE or photoreceptor degeneration in a long-standing benign lesion, and in a malignant lesion it can also detect even a small quantity of subretinal fluid and also lipofuscin. Fundus fluorescent angiography and indocyanine green angiography are not very helpful in characterizing an intraocular tumor. However, FFA can differentiate between an intraocular tumor and hemorrhage, with the latter blocking fluorescence. Indocyanin green angiography show changes in choroidal blood flow pattern in the region of the intraocular tumor but does not characterize a tumor to be choroidal melanoma. CT scan and MRI are not routinely done to characterize an intraocular tumor, but they are useful to detect and assess intraocular tumor in eyes with an opaque media. CT and MRI can also detect posterior extrascleral extension and can also be helpful in detecting distant metastasis. MRI may help in differentiating hemorrhage or vascular tumors from melanoma because on T2 weighted imaging, methemoglobin present in blood appears brighter as compared to melanin. One indication for fine needle aspiration biopsy is diagnostic dilemma in case of a small melanotic tumor. But fine needle aspiration biopsy is more commonly performed for choroidal melanomas which have already been clinically diagnosed and are being planned to be treated by globe-preserving radiotherapy. For analyzing the genetic profile of the tumor, because presently the genetic profile of the tumor is considered to be the most powerful factor determining the risk for future metastasis and thus the survival of the patient. And for this purpose, fine needle aspiration biopsy is performed immediately before radiotherapy is administered. Fine needle aspiration biopsy can be done transvitreally or transclerally for posterior uveal melanomas and transcamerally for iris tumors. Incidence of metastasis in choroidal melanoma patients at diagnosis is less than 2%. It is 25% at 5 years and 50% at 25 years after initial diagnosis and treatment. Liver is the primary site for metastasis of uveal melanoma and usually the first to be involved, and this is very important to remember. Other sites for distant metastasis include lung, bones and skin. All patients of choroidal melanoma should undergo metastatic evaluation before treatment initiation to rule out metastatic disease at diagnosis, and this is particularly important for patients with tumors in category T3 and category T4 of AJCC. We'll come to these categories a little later in this session. Systemic evaluation is also important to rule out other systemic diseases which might affect treatment, and this includes other primary cancers whose ocular metastasis can mimic a melanoma. Metastatic evaluation consists of complete physical examination with particular focus on the liver and the skin, and liver and lung imaging with contrast imaging of the abdomen and contrast or non-contrast imaging of the chest. Various combinations of imaging techniques have been recommended. PET scan has low sensitivity for metastatic melanoma because of its low avidity for fluorodeoxyglucose. Long-term surveillance for the occurrence of metastasis is recommended for all choroidal melanoma patients, and the same investigational modalities are used. However, in certain centers, CT scan is replaced with abdominal ultrasound so as to reduce the repeated radiation exposure of the patient. The NCCN recommendation for metastasis surveillance is as follows. For patients with choroidal melanoma with the tumor in category T4 of the AJCC system or with tumors with class 2 gene profile, we will be discussing gene profiling a little later. Surveillance investigations are recommended every 3 to 6 months for the initial 5 years, followed by every 6 to 12 months for the next 5 years, and then as required. For choroidal melanoma patients with their tumors in categories T2 or T3 of AJCC or with tumors having class 1b gene profile, surveillance investigations are recommended every 6 to 12 months for the initial 10 years and then as required. If imaging results suggest metastatic disease, biopsy of the metastatic site is recommended. On histopathology, uveal melanomas are composed primarily of spindle B cells and or epithelioid cells. Spindle A cells can also be present, but tumors consisting solely of spindle A cells are considered as nevi. Melanin content in the cytoplasm of tumor cells is variable, and mitotic index of uveal melanoma tumor tissue is usually low. Modified calendar classification classifies choroidal melanoma tumor tissue histopathologically into spindle cell melanoma epithelioid cell melanoma, and mixed cell melanoma. In this photograph, we see a spindle cell melanoma. In spindle cell melanoma, more than 90% of the cells are spindle cells. They can be spindle B cells with or without spindle A cells. Spindle A cells have elongated nuclei with white stripe and small nucleoli. Spindle B cells have large plump nuclei with prominent nucleoli and coarse granular chromatin. This photograph shows an epithelioid cell melanoma in which more than 90% of the cells are epithelioid cells. Epithelioid cells have abundant eosinophilic cytoplasm resembling epithelium with oval or round nuclei having prominent nuclear membrane, prominent nucleoli, and very coarse chromatin. Some of the tumor cells can be multinucleated in epithelioid cell melanoma. The mixed cell type of choroidal melanoma contains a mixture of spindle and epithelioid cells. In this session, we will be discussing how to differentiate choroidal melanoma from the most important entity in its list of differential diagnosis, that is choroidal nevus. The other important entities in the list of differential diagnosis of choroidal melanoma we will be listing in this session, but we will be discussing them individually in subsequent sessions. There is no one single definitive factor distinguishing a choroidal nevus from a choroidal melanoma. Less than 10 to 15% of choroidal nevi which remain benign on long-term follow-up demonstrate liposuction and subretinal fluid, surface features suggesting malignant nature of a choroidal melanocytic lesion. On the other hand, 10 to 60% and not all choroidal nevi which remain benign on long-term follow-up demonstrate drusen's and degenerative RPE changes, surface features suggesting benign nature of a choroidal melanocytic lesion. Frequency of drusen's and degenerative RPE changes increase with the age of the patient, and drusen's and degenerative RPE changes can also be found with choroidal melanomas arising from a pre-existing nevus. What is important to remember is that the thinner or the less elevated the lesion or the smaller the basal diameter of the lesion, the less the chance of a choroidal melanocytic lesion being malignant. Also, choroidal nevi remain stable in size or grow very slowly, and the growth particularly occurs in younger patients less than 40 years of age, and the rate of growth is less than 0.1 mm per year. In contrast, growth of a choroidal melanoma can be documented within 1 to 3 months. Risk factors for growth of a choroidal melanocytic lesion are very important, and they are known as the TFSOM criteria, acronym for to find a small choroidal melanoma. TFSOM criteria stands for thickness of the tumor more than 2 mm, subretinal fluid, occurrence of symptoms such as photopsia, metamorphopsia or visual field defect, orange pigment on the surface due to liposuction, and margin of the tumor touching the optic disc. Other factors which suggest malignant nature of a choroidal melanocytic lesion are larger size, as we have discussed, absence of drusen or degenerative RPE changes, which are surface features suggesting benign nature of a choroidal melanocytic lesion, homogeneous low intensity on ultrasound, as we have discussed, and hot spots on fundus fluorescein angiography. When any of these risk factors are present in a choroidal melanocytic lesion, we can either follow up the patient closely with fundus photography, ultrasonography, and optical coherence tomography, or perform fine needle aspiration biopsy transsclerally or transvitreally for cytology and molecular genetic testing. Among the other differentials of choroidal melanoma, we have benign tumors such as choroidal osteoma, choroidal hemangioma, melanocytoma, adenoma of RPE, simple hamartoma of RPE, and combined hamartoma of retina and RPE. Among malignant tumors, we have choroidal metastasis and adenocarcinoma of RPE. Non-neoplastic lesions which can simulate choroidal melanoma or other choroidal tumors include acquired hyperplasia of RPE, choroidal detachment, neovascular AMD, varix of the vortex veins, and peripheral hemorrhagic chorioretinopathy. These 5 entities we have discussed in the previous session, and the remaining we'll be discussing in subsequent sessions. So this is a very important differential diagnosis list of non-pigmented choroidal lesions, and herein we have tumors such as amelanotic choroidal melanoma, choroidal hemangioma, choroidal osteoma, choroidal metastasis, and inflammatory lesions such as choroidal granulomas and posterior scleritis, as well as serous choroidal detachment. There are two classification systems for posterior uveal melanomas: the Collaborative Ocular Melanoma Study System and the American Joint Committee on Cancer System. The Collaborative Ocular Melanoma Study System classifies the intraocular tumor based on its apical height and largest basal diameter into small, medium, and large choroidal melanomas. Small choroidal melanomas are defined to have an apical height of between 1 to 2.4 mm and largest basal diameter between 5 and 16 mm. Choroidal melanomas in the medium category are defined to have an apical height of between 2.5 to 10 mm, which has been later modified to an apical height of between 3.1 and 8 mm, and largest basal diameter of not more than 16 mm. Large choroidal melanomas are defined as having an apical height of more than 10 mm and the largest basal diameter of more than 16 mm. These two figures are important because choroidal melanomas with an apical height of more than 10 mm and largest basal diameter of more than 16 mm, and thus falling under the large category, cannot be controlled with a brachytherapy plaque and require enucleation. The 8th edition of AJCC TNM classification is presently the most commonly used classification system for choroidal melanoma. The AJCC TNM classification for choroidal melanoma first categorizes and then classifies the primary tumor. It also takes into account the lymph node involvement status, presence of metastasis, and tumor grade. So the primary tumor is first categorized into 4 categories based on the thickness and the largest basal diameter, and each category have multiple combinations of thickness and largest basal diameter. After the primary tumor is categorized into 4 categories based on its size, each size category is further subclassified into 4 subcategories based on presence of ciliary body involvement and presence of extraocular spread. The tumor belongs to A subcategory if it does not involve the ciliary body or other parts of the eye and does not have extraocular spread. The tumor is classified into B subcategory if it involves the ciliary body but it does not have extraocular spread. The tumor is classified into C subcategory if it has an extraocular spread of less than 5 mm in largest diameter but without ciliary body involvement. And the tumor is classified into D subcategory if it both involves the ciliary body and also has extraocular spread but less than 5 mm in largest diameter. Then we have this T4E subcategory in which tumors with extraocular spread of more than 5 mm in largest diameter are included irrespective of their primary size category. So what is important to remember is that apart from size of the primary tumor, involvement of the ciliary body and presence of extraocular spread are important in the classification of the tumor in the AJCC system. The AJCC system also takes into consideration the presence of lymph node involvement, presence of metastasis, and the histopathologic grade of the tumor in classifying choroidal melanoma patients. And the subcategories for node metastasis and grade of the tumor is similar to the AJCC classification for iris melanomas, which we have discussed in the previous session. The AJCC system stages choroidal melanoma patients into one of 7 stages based on his or her T, N, and M status. We here note that patients with lymph node involvement or presence of distal metastasis belong to stage 4. According to data published in 2015, 88% of all choroidal melanoma patients belong to stage 1, 2A or 2B at diagnosis. 33% of all choroidal melanoma patients at diagnosis belong to stage 2A. As expected, 5-year and 10-year survival rates are best for patients in stage 1. but the 5-year survival rates and the 10-year survival rates gradually decrease as the stage becomes higher at diagnosis with larger primary tumors, ciliary body involvement, and extraocular spread. Patients in stage 4 with lymph node involvement or presence of distant metastasis have a drastic reduction in their 5-year survival rates and 10-year survival rates. The primary aim of treatment of patients with posterior uveal melanoma is to prevent or at least delay the occurrence of metastasis, the primary cause of death of patients with posterior uveal melanoma. Large and active melanomas must be treated, and these lesions do not require biopsy. However, large lesions can be observed instead of treated in either very elderly patients or in patients with systemic illness precluding treatment. Treatment decisions for small posterior uveal melanocytic tumors are more difficult. Treatment of these lesions are indicated when there is presence of any of the 5 TF-SOM criteria for growth. But if none of the TF-SOM criteria are present, patients can be given informed options of monitoring for growth of the lesion and treating when growth of the lesion is documented, performing a fine needle aspiration biopsy, or treat the lesion directly without performing a fine needle aspiration biopsy. The primary modalities of treatment of posterior uveal melanoma are enucleation and radiotherapy. We may note here that chemotherapy, which is the cornerstone of treatment for retinoblastoma, have no role in the treatment of posterior uveal melanoma. Indications for enucleation include blind and painful eyes with choroidal melanoma, tumors greater than 16 mm in basal diameter and 10 mm in thickness, which are difficult to control by radiotherapy, and tumors surrounding or invading the optic disc. We may note here that margin of the tumor near the optic disc is one of the TF-SOM criteria. Radiotherapy is the primary globe-sparing treatment for posterior uveal melanomas, and brachytherapy is the most common form in which radiotherapy is administered for choroidal melanoma. Indications for brachytherapy of choroidal melanoma include choroidal melanoma smaller than 16 mm in largest basal diameter and less than 10 mm in apical thickness, and choroidal melanomas not surrounding or invading the optic disc. Brachytherapy is administered with a radioactive plaque placed on the sclera over the tumor and containing usually iodine 125, which emits gamma rays, or ruthenium 106, which emits beta radiation. Brachytherapy delivers a very high dose of radiation to the tumor while minimizing the radiation exposure to the surrounding normal structures. Intraoperative localization of the tumor and the radioactive plaque with ultrasound improves local tumor control. Following brachytherapy, some tumors completely flatten, most tumors decrease in size, but some tumors show no change. Although clinical and ultrasonographic evidence of response to brachytherapy may be seen. So here in this photograph we see a choroidal melanoma before and after administration of brachytherapy. Following brachytherapy, surveillance should be continued with fundus photography and ultrasonography to detect tumor recurrence. Tumor recurrence, though rare, can occur either in the margin of the tumor or more diffusely throughout the tumor. Charged particle radiation emitting protons or helium ions produce high energy focused radiation with lesser lateral spread than brachytherapy plaque. They also deliver a more homogeneous dose of radiation to the tumor. Tumor control rates of up to 98% has been reported with charged particle radiation. In this technique, tantalum clips are attached to the sclera surgically, with the help of which the tumor is located with CT or MRI scan during delivery of the radiation. But this form of radiotherapy is not available universally. So far as external beam radiation therapy is considered, conventional EBRT, in which lower dose of radiation per fraction is administered over many fractions, is considered to be ineffective for the treatment of uveal melanoma. However, fractionated stereotactic radiotherapy, also called gamma knife surgery, has been found to be effective for the treatment of uveal melanoma. And in fractionated stereotactic radiotherapy, a higher dose of radiation is administered per fraction and is focused with CT or MRI guidance and is administered over fewer fractions to deliver the total radiation dose. More than 50% of patients treated with radiotherapy for choroidal melanoma have radiation-induced complications, and these complications are dose-dependent and occurs after a delay of 1 to several years. These complications include maculopathy and optic neuropathy as shown here in this photograph, and radiation-induced maculopathy and optic neuropathy occurs due to damage to the vasculature of the retina and the choroid. Most of these patients are given a trial of anti-VEGF injection for the treatment of the radiation-induced maculopathy and optic neuropathy, but the efficacy of anti-VEGF in this situation is not known. Other complications of radiation therapy include exudative retinal detachment, neovascular glaucoma, cataract formation, and chronic dry eye. Lid margin scarring has been shown to occur following charged particle radiation. Alternative therapies for the treatment of the primary tumor in choroidal melanoma includes transpupillary thermotherapy, which is no longer used alone because of the high rate of local recurrence as compared to brachytherapy, but currently it is sometimes used as an adjunct to brachytherapy and for recurrences following brachytherapy. Transscleral resection or transvitreal endoresection of choroidal melanoma tumor has been advocated by some in young and healthy subjects in whom the tumor does not involve either the retina, the macula, or the optic nerve. But this form of treatment for choroidal melanoma must always be accompanied by adjuvant radiotherapy. Immunotherapy is partially effective for treatment of metastatic disease but is ineffective for the primary choroidal tumor. As we have discussed, chemotherapy is ineffective for both primary choroidal tumor as well as metastatic disease. Exenteration was traditionally used for choroidal melanomas with extrascleral extension. Currently, enucleation with tenotomy and or radiotherapy is recommended for tumors at this stage. Exenteration is done only infrequently currently, and that too for debulking advanced orbital invasion only. Treatment options for metastasis of choroidal melanoma are limited, and overall efficacy of treatment for metastasis is still uncertain. The treatment options include surgical resection of the metastatic tumor, hepatic intraarterial chemoembolization or radioembolization with particles containing chemotherapeutic or radiotherapeutic agents, and immunotherapy. Immune checkpoint inhibitors, which we have mentioned in the treatment of cutaneous melanomas of the eyelid, have not been found to be satisfactorily effective for metastatic uveal melanomas. However, tebentafusp improves survival and has been FDA approved for the treatment of metastatic uveal melanoma patients with a specific HLA subtype. Tebentafusp is a bispecific T-cell engager which attaches to both the CD3 molecule on the surface of helper and cytotoxic T-cells and a GP100 protein on melanoma cells, thus targeting the T-cells to the melanoma cells. Prognostic factors for patients with choroidal melanoma are described as clinical, genetic, or histopathological. Clinical risk factors determining melanoma-related mortality include large tumor, ciliary body involvement, extraocular extension, older age, rapid tumor growth, and tumor regrowth after globe conserving therapy. The first three criteria are in the AJCC system. Genetic risk factors for metastasis are genetic mutations and chromosomal rearrangements in the tumor, and they are currently regarded as the best method to prognosticate the future risk of distant metastasis, and they include monosomy of chromosome 3 with or without gain of chromosome 8. Genetic profile of the tumor, with class 2 tumors having a worse prognosis than class 1b tumor, which in turn has a worse prognosis than class 1a tumor. Genetic profiling analyzes the genetic status of the tumor as regards a specific set of genes. Mutation of BAP1 gene is regarded as very important in determining the future risk of distant metastasis, and currently mutation of BAP1 gene is included within genetic profiling. Specimen for genetic analysis of choroidal melanoma can be either freshly enucleated or resected tumor or material from fine needle aspiration biopsy performed immediately prior to administration of radiation. Histopathological features which also determine the future risk of metastasis include a predominance of epithelioid cells, an increased mean diameter of 10 largest nucleoli, a high mitotic index, increased vascularity of the tumor, tumor cells arranged in loops and networks of loops as seen here in this photograph, and tumor infiltration with large numbers of lymphocytes and histiocytes. However, invasion through Bruch's membrane does not worsen the prognosis for choroidal melanoma. The collaborative ocular melanoma study, which was so very important in determining the treatment for various categories of choroidal melanoma. They had three arms: the large choroidal melanoma arm, the medium choroidal melanoma arm, and the small choroidal melanoma arm. The large choroidal melanoma arm study included tumors more than 16 mm in basal diameter and or greater than 10 mm in apical thickness, and this arm compared enucleation alone versus enucleation preceded by EBRT. It found no significant difference in the all-cause mortality rates, but there was a lower risk of orbital recurrence when enucleation was preceded by radiotherapy. So this arm established that enucleation alone was an appropriate therapy for large choroidal melanoma which are not amenable to globe-conserving radiotherapy. The medium choroidal melanoma arm included patients with tumors 8 to 16 mm in maximum basal diameter and or 2.5 to 10 mm in apical height, and this arm compared enucleation versus iodine 125 brachytherapy, and it found no significant difference in the rates of all-cause mortality or rates of histologically confirmed metastasis. However, in the brachytherapy arm, there was a local recurrence rate of 10% in 5 years, and there was a decline of visual acuity due to radiation-induced complication in almost 50% of patients after 3 years. The small choroidal melanoma study included patients with tumors 4 to 8 mm in basal diameter and or 1 to 2.5 mm in apical height. It was only an observational study without administration of any treatment to these patients, and this study found that many such tumors did not grow. To recap the salient points, posterior uveal melanomas including choroidal and ciliary body melanomas are the most common primary malignant intraocular tumor. Risk factors include fair skin, choroidal nevi, oculodermal melanocytosis, and genetic predisposition. Posterior uveal melanoma patients can be asymptomatic or may present with photopsia, blurring of vision, visual field defect, or pain from secondary glaucoma. Clinically, the dome-shaped pattern of growth is the most common, but the mushroom-shaped pattern of growth is the most characteristic of choroidal melanomas. The mushroom-shaped pattern of growth occurs due to breaking of the tumor through the Bruch's membrane. Surface liposuction and serous retinal detachment over the tumor suggests malignant nature of the tumor. Ciliary body melanomas are usually detected late because of their location. Sentinel vessels or epibulbar pigmented nodules may suggest the presence of an underlying ciliary body melanoma. Red reflex and transillumination tests helps in diagnosis when such a tumor is not clinically apparent otherwise. A-scan ultrasound of choroidal melanoma shows high reflectivity of the anterior border of the tumor, low internal reflectivity of the tumor, and spontaneous vascular pulsations within the tumor. B-scan ultrasound shows the shape of the tumor, homogeneous echogenicity within the tumor, choroidal excavation, and orbital shadowing. Fine needle aspiration biopsy is indicated in diagnostic dilemma but is more commonly used for genetic profiling of tumors before treatment with globe-sparing radiotherapy. Histopathologically, a predominance of epithelioid cells over spindle cells suggests a poor prognosis for the patient. All choroidal melanoma patients should undergo metastatic workup prior to treatment and metastatic surveillance after treatment. The predominant site of metastatic involvement in choroidal melanoma patients is the liver. Indications for treatment of choroidal melanoma include small choroidal melanomas with any of the TF-SOM criteria present and large choroidal melanomas. COMS recommended enucleation for large choroidal melanomas, brachytherapy or enucleation for medium choroidal melanomas, and observation only for small choroidal melanomas. Treatment of choroidal melanomas is either by enucleation or by radiotherapy. Chemotherapy has no effect. Predominant cause of melanoma-related death is liver failure from liver metastasis. Various treatments are available for metastatic melanoma, but none has been found to prolong survival significantly. Genetic mutations and chromosomal rearrangements found in the tumor are now considered as more important than clinical and histological factors in predicting the risk of metastasis. Thank you for listening.